My name is Raúl Febles. I'm a physiotherapist, and I'm doing my PhD at the University of La Laguna. Today, I'm going to speak about exercise in renal patients, the real benefits in a specific population. As you know, exercise has multiple benefits for the health, and here you have summarized some of them. I would like to highlight the last one in the reduction of the risk of cardiovascular disease and type 2 diabetes. But is there any role for exercise in post-transplant diabetes mellitus? These are 3 classical studies made in the general population. The first one was made in China and include more than 500 patients. The second one was made in the US, the Diabetes Prevention Program, that include more than 3,000 patients. And the last one is the Finnish study. All studies include exercise as a tool of prevent diabetes mellitus. These studies give us the information that exercise could be a good option to prevent diabetes. These studies share that all patients included in them are pre-diabetics, so they are patients at risk of diabetes. So all subjects were pre-diabetic patients. Here, as you can see in this graph, the cumulative incidence of diabetes in the Diabetes Prevention Program that include patients randomized to the exercise group, metformin, and placebo. And clearly, and you can see, exercise provide the best option to prevent diabetes, with a cumulative incidence only around 20% if you compare with metformin or placebo. So, based on that, can we apply this information to PTDM prevention? In the general population, exercise can prevent type 2 diabetes, of course, in patients at risk. That means pre-diabetes. But, first of all, we have to define PTDM. What is PTDM? PTDM is a disease with many similarities with type 2 diabetes mellitus. It affects around 20–30% of patients, or renal transplant patients, and is associated with cardiovascular disease and infection. But it differs from type 2 diabetes mellitus in its clinical evolution. As you can see in this graph, the incidence increased in the first 3 months after transplantation, followed by the period of reversibility, and then the incidence increased again. As you can see, PTDM has a bimodal evolution. First period is known as early PTDM, and it occurs after 3 months after transplantation, maybe due to the use of steroids, immunosuppressants, and so on. And the second peak of incidence occurs after 12–24 months after transplantation. Between that, there is a period that is known as spontaneous reversibility. In the first period, that it's known that early PTDM, we think that exercise could not have a role, maybe because patients are unstable, the use of immunosuppressant, steroid, and so on. So we think that exercise could have a role in late PTDM. So, stable patients beyond 9–12 months after transplantation with prediabetes is our target population in whom exercise may prevent PTDM. But there is few evidence in this field. To the best of our knowledge, only 2 studies are used to study the PTDM prevention. The first study included 111 patients, 79 with normal glucose metabolism, only 7 with PTDM, and 25 with IGT. Patients were allocated to exercise and control group, and the exercise group practiced at least aerobic exercise training 2 hours per week. The main follow-up was 8 months to 6 to 12 months, and no major significant difference were found in this study. And the second study included 20 patients, but with prediabetes, and patients were allocated again to exercise and control group, and patients practiced exercise training 3 times per week, and the mean follow-up was less, only 4 months. And again, no significant difference were found in this population. So we have many questions to solve. The first one, can exercise prevent PTDM? We don't know yet. Is exercise effective in this population? We don't have enough data. And what about safety? Can exercise revert or prevent PTDM beyond the spontaneous reversibility? We don't know. And which exercise? Aerobic exercise training, resistance, combined, HIIT, interval training, for how long? Only a few weeks, 1 month, 2 months, a year? We don't know. And what about intensity? Low intensity is enough? Moderate? High intensity? And frequency and duration? We don't know anything about that. And finally, one of the most important aspects when you prescribe exercise is adherence. When you prescribe exercise, you have to control this parameter, because if not, failure is at the gates. It's very important to control the adherence in these patients. So, due to this large gap in knowledge, we decided to design an exploratory and preliminary study known as SPREAD, Exercise and Prediabetes After Renal Transplantation, that has been recently published in Nephron. The main objective of this study is to induce the reversibility of prediabetes by exercise training, of course in renal transplant patients. As a secondary objective is to evaluate adherence of exercise, and also improvement in metabolic risk factors profile, such as obesity, triglycerides, blood pressure, and so on. These are the inclusion and exclusion criteria. Of course, we include only patients at risk, that means prediabetic patients. Of course, more than 12 months after transplantation, so only late PTDM patients, and patients are clinically stable. So there is no available evidence on the efficacy of exercise in preventing PTDM. So that's the reason that we designed a preliminary exploratory analysis to evaluate the feasibility of exercise to reverse prediabetes, and then to have information to design a future clinical trial to prevent PTDM. Here you have the screening procedures. All patients who have impaired fasting glucose were directly included in the study. However, in order to detect a concomitant IGT, they underwent an OGTT. To select patients without impaired fasting glucose, we use the following criteria: a BNI more than 27, and a level of triglycerides more than 150. Of course, if patients have IGT, they were included, and then if not, they were excluded. These are the intervention and outcomes that we use in this study. The study lasts 12 months. All patients at baseline perform an OGTT, an analytics, and a cardiorespiratory fitness test to know about the physical functioning. And at baseline, we prescribe the SSI training, and then we start with the adherence protocol. Every 3 months, we perform an OGTT in order to detect the reversibility or persistence of prediabetes up to the end of the study. Exercise is prescribed and controlled by a trained physiotherapist. The treatment is based on response and it's incremental. And simultaneously, at month 0, we start with the protocol of adherence. All patients in this study have the same treatment at baseline. That's it. Aerobic exercise training, 5 times per week, at 30 minutes per day, in an intensity of moderate intensity, in exercises such as brisk walking, cycling, or equivalent, also swimming as well. If there is improvement, that's mean the reversibility of prediabetes, exercise remain the same and change this prescription. But if there is no improvement, exercise change as follows, as you can see here. Aerobic exercise training of 45 minutes 5 times per week. And again, if there is no improvement, we use aerobic exercise training 60 minutes per week, 60 minutes per day 5 times per week. And also at the end, at 9 months, we add resistance training in case of no reversibility of prediabetes. The adherence protocol uses the active control, that is frequent telephone calls to patients, and all patients wear a bracelet activity tracker in order to have objective measures of exercise training. And then we evaluate the response based on an OGTT and the reduction of weight and the analytics, anthropometric measures, and so on. In order to increment adherence of patients, we use intermediate visits, the reinforcement of the protocol and the importance of the SSI to control diabetes mellitus, and then we increase the telephone calls. But we do not have any data to classify adherence to exercise. So we decide to divide adherence in 3. The first one is an accomplishment around 70% and is known an acceptable adherence. A moderate adherence, that means 40 to 70% of an accomplishment. And the last is bad adherence, less than 40%. We have screened 51 patients, and we already include 29, but we are only follow up 27 patients. And here you have the results. We have a total reversibility of 64%, 16 of 25. We have a partial reversibility, that means patient who is still prediabetes but have major changes, for example, from 190 to 142, 4 of 25, that is 16%, and no response in 20% of patients. So we have major changes in 80% of patients. Up to this day, we don't know. And if we link adherence with the results, we have a total reversibility in patients who have an acceptable accomplishment in 12 of these patients. We have partial reversibility in patients with moderate adherence, and we have no response in patients with bad adherence. But we have moderate adherence and total reversibility, and also we have acceptable adherence and partial reversibility. And also we have no response in patients with acceptable and moderate. Maybe SSI is not enough, maybe the follow-up is not enough. We don't know yet. And also, as Esteban mentioned before, we have gender difference in the response to exercise. Up to this day, we have a total reversibility of in women about 50% and no response in the other 50%. However, in men, we have a total reversibility of 65% and a partial reversibility of 23%, approximately a change in 90% of men, if you compare with women. The adverse events found during this study was practically nothing. 1 patient iliotibial band syndrome, and 2 patients plantar fasciitis. And here you have the conclusions. So, exercise is effective in reverting prediabetes. Exercise is then effective in patients really at risk. We have a simple and reproducible protocol. It's not a build tray. We have a step-tailored training, and it's according to response. It's tailored suite. And also, as I mentioned before, adherence is part of exercise treatment. So, can we apply this information? Based on this result, we decided to apply to the National Institute to design a clinical trial to prevent PTDM in the Canary Island, in the main hospital of Canary Island. So this is my village that has been recently named as one of the best villages of Spain, and you are all invited to celebrate the next meeting there. And thank you very much for your invitation.
Thank you very much, Raúl. So are there any questions from the audience, despite knowing the city? Yes.
Thank you for a very nice presentation. Do you assess why the adherence is lacking for some individuals?
What?
Do you ask them why they do not train, the ones who do not train? Playing the violin.
It's difficult, but we can't do anything to that.
They lie very well, and you know they are lying. That's simple.
But that's the reason why we use the activity tracker in order to have objective measures.
So I have a question. Did you find any difference in the disease state between the two groups? Like, did the exercise group had less infections, less hypertension, less disease activity, maybe fewer rejections? Were there difference in rejections? Because it was transplanted patients with the normal outpatient clinic follow-up.
Yeah, we just finished this preliminary data some weeks ago, and we found we have potency enough to stop earlier the study. We're going to analyze the characteristics of you're saying the GFR they were all stable regarding renal damage. So, but we will do that. This is something we need to check yet.
Hi, I have a very basic question based on the exercise, the relationship of exercise and diabetes, which is actually also a question for also other related lectures I have listened this morning. So have you ever considered about the work of the patient? Because people may have very diverse work or other exercise.
People frequently are very busy, and it's difficult to have time to do exercise training. And mainly in women, it's more difficult.
Okay, because I was wondering, because some people may have a lot of physical work already, and some
Yes,
people.
but
are
it's
just
not
working.
considered. Physical training is in the other side, and exercise training is in the other side. We only take in account the exercise training, not physical functioning at works, for example, on the leisure time.
Okay. Have there any other studies like they have this paired organization, like they have similar condition of patients in different groups, and while doing this exercise?
This is made in the general population, but not in post-transplant. On renal transplant patient, there is no data about that. And in the general population, there is data for that
Okay. Yeah. Thank you.
with a large sum.
Raúl, there is a question from the audience. Did reversibility depend on the progression of your exercise protocol? In example, the volume of exercise? The reversibility.
The reversibility rate that we found appears more or less at 6-9 months.
6 to 10 months, okay.
Yeah,
In the middle, more or less.
in the middle, yeah.
Okay.
Because the acute chain is not as
Need
good
time.
as the middle chain.
Hi. I was wondering whether so you had a subgroup where you mentioned that the treatment didn't work, but as far as I understood, they were stable. So could the exercise had worked anyway, meaning that if they didn't perform any exercise, that they would have further impaired their glucose tolerance? Based on your first graph, you saw a reduction after those 3 months, and then you have a reoccurrence of the pre-diabetes. So I was just wondering whether it actually still protected them towards aggravating disease further.
Regarding, we don't know. What we really know is that they are still at risk for cardiovascular events, because we found in our previous study that this is a risk factor as in the general population. But if they are still protected against cardiovascular events or the incidence of PTDM, we need more time. 2 years 12 months is a short period for that. But it's a good point to think about that.